So I know we've talked a lot about CPR, and as you can see, CPR has a rich history. But however, not much has changed since the 1960s in terms of the actual hands on the body that we've done. But what has changed a lot in terms of our understanding of CPR has to do more with what happens after someone is revived from cardiopulmonary arrest. And what we kind of understand at this point is that there's actually two mechanisms of injury. So there's the first type of injury, which we've talked about when there's actually hypoxia to the brain. And then there's the second injury that happens when there's inflammation. And I like to think about this in a simplistic way, and it's kind of when you get hit. So when you initially, if you got hit on the arm, you would initially have the time in which you got hit, and that would cause pain. And then maybe the next day you'd notice that your arm hurt when you touched it, and that's from the inflammation that's actually causing the secondary pain. And so if we can do something in order to mitigate that risk of having the inflammation, that's actually what would cause that long-term pain that we're having. And if it occurs in the brain, ultimately problems in the brain. So if the brain cells don't actually die within minutes, when do they die and how do they die? And we've had a lot of slides that have talked about this, and since we're a little short on time, I will not hit it again. However, the important things are to know that not just oxygen depletion, but actually things that happen on the cellular level occur with hypoxia, and that when the person is reperfused, that actually sets off inflammation and other cellular mechanisms, cascades, which we could possibly target in order to mitigate these risks. So Sam talked about how the ischemic event might be similar to a earthquake, and that the reperfusion event is actually the tsunami that results over it. And if we can't stop the earthquake from happening, perhaps we can stop the tsunami from occurring, or at least mitigate the tsunami. And this is not a new concept, however, it is a concept that we're working on, and we can see papers going back to the 70s showing the idea that while we can restart the heart, that then the second step of the actual resuscitation arises, and this is what we're focusing on, this post-resuscitation disease. And why do we know that this post-resuscitation disease is so important? So if we take all comers who have CPR, we have the initial people who do not survive the cardiopulmonary arrest, and that can happen at about, let's say that's about 60% of people. We actually see more people die in this post-ischemic time. So the second hit phenomenon, and this is where we see about 75% of people drop off. So how do we focus this? We've heard a lot about targeting temperature control, so that's things in the brain to slow metabolism, control seizures, allow adequate oxygen delivery and blood to the brain. We've also talked about ways to restart the heart, so this would be ideas to increase cardiac output or keep cardiac output sufficient in order for the brain to see the oxygenation. And then how do we target this inflammation process, and what mechanisms are good for that? So this is out of the guidelines, and I think this has been hit a lot, but what we'd like to avoid doing is to be able to prognosticate really, really early. We don't know how people are going to do early, and I think we should all at least wait until 72 hours in order to start to give any sort of prognostication. So what can we do in order to help with the neuroprotection? So this is a very busy slide, and I don't want to get too bogged down into the details, but I think that there are 4 mechanisms that you should look at, and these are what's seen in the boxes. So the NMDA activation, the oxidation injury, the inflammation, the mitochondrial damage, and these are all pillars that we can work towards with medications in order to try to best protect neurons after cardiac arrest. So this is a drug looking at magnesium. Magnesium works on the NMDA receptor, and this is given in the post-arrest cycle. And what they saw was, while there was no impact on survival, that patients who received reasonably high dose magnesium actually had improved neurologic status if they did survive. And so what that says is there must be a neuroprotection mechanism for it. And people were able to have meaningful outcomes, meaning that they were able to live independently as opposed to live in a facility, which, if you're someone who has survived a cardiac arrest, would be very meaningful. There's also looks at coenzyme Q10, which works on the mitochondrial transport chain, and that showed a survival benefit at 3 months. There are studies looking at inhaled xenon gas, and while this study wasn't powered to actually show a mortality benefit, what it did show was that on MRI there was improved in white matter changes. So by giving inhaled xenon, which works by the NMDA receptors as well, that this would preserve brain tissue. And this is a study looking at vasopressin, steroids, and epinephrine in cardiac arrest. And basically what it showed was that the use of vasopressin and steroids in conjunction with epinephrine showed favorable neuroprotection. And the idea behind this is twofold. One, that steroids decrease inflammation from an inflammatory pathway, and two, that vasopressin can vasodilate to the brain, and thus you can have improved oxygenation to the brain. So where do the challenges lie, and why have we not found the answer yet? I think a lot of people have talked about how heterogeneous the population who progressed to cardiac arrest is. So not all comers are equal, and I can't tell you who will survive a cardiac arrest and who won't. And thus the predisposing conditions, or the premorbid conditions, have a lot to do with how the patient will recover afterwards. Additionally, the mechanism of injury from cardiac arrest can be very different. So we've heard about people who die from trauma, people who die from cardiac arrest. The mechanism of injury, while ultimately resulting in hypoxia to the brain, has reversible states or underlying inflammatory states that go along with it that could also impact these. And so actually being able to tease out a patient population in order to study this has proven to be very difficult. So this is the whole team at NYU that focuses on cardiopulmonary arrest. It is not a short list, definitely, and just showing that all of our work is being done all over the country, and I thank everyone for their time.